Welcome back to the deep dive. We're here to tackle some really complex source material so you don't have to spend your whole weekend drowning in textbooks.
That's the plan.
And today, yeah, it's a big one. We're trying to decode that whole metabolic axis, calcium, phosphate, parathyroid hormone, vitamin D.
It's definitely a system known for causing, well, a lot of diagnostic headaches.
Right, because the symptoms often look so similar. Muscle cramps, tingling, maybe confusion, bone pain. It could be so many things.
And that's where our sources come in. They're dense, really focused on diagnosis, pathophysiology, covering everything from, say, nutritional issues right up to rare cancers and genetic stuff.
So for you listening, our mission isn't just to list conditions. It's about giving you a clear, kind of synthesized way to understand the common imbalances. And really crucially, how to read those lab patterns like a roadmap.
Exactly, cutting through that confusion.
Because that's the goal, right? Precision. A patient comes in, neuromuscular irritation, confusing picture. Is it just a supplement issue? Or is it something much more serious, like a tumor? Often comes down to just three numbers: calcium, phosphate, PTH.
That relationship is everything.
So the big question we're tackling is how do we use that relationship to tell the difference quickly between, say, a drug side effect and a genetic syndrome? And also, how does major systemic stress just completely mess this whole balance up?
And that's the synthesis we're aiming for. It's all connected.
Okay, let's unpack the core system then. We often think of PTH, parathyroid hormone, as the rapid responder, right? Jumping in quickly if calcium drops.
Yeah, the acute regulator.
While vitamin D is more the long-term manager, ensuring supply through the gut.
That's a good way to frame it. Chronic stabilizer. So what happens when that first responder, PTH, just fails? When it's deficient?
Okay, so that's primary hypoparathyroidism.
That's the definition, yes, a state of PTH deficiency. And understanding the why here is fundamental. PTH basically hits three targets to get calcium up.
Okay. First, kidneys tells them to reabsorb more calcium. Second, bone gets osteoclasts working to release calcium. And third, this is critical for the whole axis, it tells the kidney to activate vitamin D. Flip that switch from the inactive 25-hydroxy form to the active 1025-dihydroxy form.
So if PTH is missing, all three things just stop happening.
All three fail simultaneously. It's a cascade.
Wow. So the body just can't get calcium. Can't absorb it, can't get it from bone, can't even hang on to it in the kidneys.
Precisely. So you get hypocalcemia, low calcium, but, and this is key, you have to look at the phosphate too.
Right, because PTH normally gets rid of phosphate.
Exactly, it's phosphaturic.
Yep.
Tells the kidneys to dump phosphate. So when PTH is absent, phosphate excretion plummets. Levels build up, you get hyperphosphatemia.
Okay, so that's the pattern. Low calcium, high phosphate, that's clue number one.
That's your first big diagnostic flag.
And clinically, this translates into that neuromuscular excitability stuff. Oh, absolutely. And it can be quite alarming. Calcium normally stabilizes nerves and muscles. Low calcium means they get twitchy, irritable.
So the tingling around the mouth, fingertips.
Often the first sign, yeah. Perioral tingling, paresthesias. Then it can escalate muscle cramps, those weird carpopedal spasms where the hands and feet lock up. Even full tetany or seizures if it's really severe.
And the heart.
Yeah, that's a big worry. On the ECG, you look for a prolonged QT interval. That significantly bumps up the risk for dangerous arrhythmias.
So if someone shows up with tetany, tingling, and they haven't just had neck surgery, which is a common cause, right, damaging the glands?
Yeah, iatrogenic hypopara, very common post-surgery.
But if it's not surgical, what's the usual culprit the sources mention?
The high-yield cause, the one to really think about, is autoimmune hypoparathyroidism. The body is attacking its own parathyroid glands. And that lab pattern we talked about, it's just so specific for primary hypoparathyroidism. Low calcium plus high phosphate plus low or inappropriately normal PTH, and importantly, normal renal function. See that combo? You've pretty much nailed the primary regulator failure.
And managing it means basically bypassing that failed PTH signal.
Exactly. You have to give calcium supplements, obviously, but crucially, you need active vitamin D analogs, like calcitriol, because without PTH, the kidney can't make the active form itself.
Right, because the activating enzyme isn't getting the signal.
Correct. So just giving plain vitamin D or calcium won't cut it. The calcium won't get absorbed properly without that active 1025 vitamin D. You need the final product.
Okay, this leads us right into those diagnostic contrasts because, like you said, lots of things cause low calcium. But the phosphate level, that's the tiebreaker.
It's often the key differentiator, yes.
So let's take simple vitamin D deficiency. Lack of sun, poor diet. How does that lab pattern differ?
Okay, here the system is actually working or trying to. With low vitamin D, you're not absorbing calcium and phosphate well from your gut. Calcium drops.
And the parathyroid glands notice this.
Immediately, they sense the low calcium and they react. They start shouting for PTH, so PTH levels shoot up. This is secondary hyperparathyroidism. The glands are working overtime to compensate.
So PTH is high, trying to fix it.
High and doing its job. That high TTH forces the kidneys to hang on to calcium, which helps, but it also aggressively pushes phosphate out into the urine.
Ah, so that's the difference.
That's the key. The hallmark of vitamin D deficiency, unlike primary hypopara, is low calcium with an appropriately high PTH and crucially low phosphate. That low phosphate tells you PTH is present and active.
Wow. Okay. So primary failure, high phosphate. Secondary compensation, low phosphate. That really clarifies things. But where does chronic kidney disease, CKD, fit? Because that also causes calcium problems and high phosphate, right?
CKD. Yes, the great confounder. It mimics bits of both. With failing kidneys, two things happen regarding this axis. One, they can't excrete phosphate properly, so phosphate levels rise, hyperphosphatemia right there.
Okay.
Two, they lose the ability to do that final vitamin D activation step, the 1-hydroxylation, so you can't make active vitamin D result. Poor calcium absorption from the gut.
Which then drives PTH up again.
Exactly, trying to compensate for the low calcium, so you get secondary hyperparathyroidism again.
Okay, hold on. So CKD gives you low calcium, high phosphate, and high PTH. Primary hypopara gave us low calcium, high phosphate, but low PTH. How do we tell those apart?
Two main things. First, the PTH level itself. In CKD, it's inappropriately HIGH, trying its burst. In primary hypopara, it's LOW because the glands themselves have failed.
Got it.
Second, the context. The patient with CKD has, well, kidney disease. You'll see elevated creatinine, low GFR, clear renal dysfunction. If the kidneys are working fine and PTH is low, it's primary hypopara. If the kidneys are shot and PTH is high, think CKD.
And just to round it out, what if someone just isn't eating enough calcium? Pure dietary lack.
Same principle, essentially. It triggers secondary hyperparathyroidism. The body senses low calcium intake. PTH rises to maintain blood levels, mainly by pulling calcium from bone.
And that high PTH again means?
Low phosphate. It forces phosphate excretion. So again, high PTH usually pairs with low phosphate unless the kidneys themselves are failing and simply can't get rid of the phosphate.
Okay, that pattern logic is really helpful.
So this brings up a really important point. When we do see that pattern, low calcium, appropriately high PTH, low phosphate, we know it's secondary hyperparathyroidism. The glands are responding correctly to some kind of supply issue.
And the most common supply issue is vitamin D.
By far the most common, yeah. But it's not always just lack of sun or diet. We need to dig into some other high-yield reasons why vitamin D might be low.
Right. So the basic mechanism is low D leads to poor absorption, low calcium, high PTH. What's the definitive test? How do we check the body's actual vitamin D stores?
The single best test is the serum 25-hydroxyvitamin D level. That's the main circulating storage form made in the liver. It reflects the total amount you have from both sun and diet.
Why not the active form, the 1025 dihydroxy-D?
Because the active form is really tightly regulated by PTH. Early in deficiency, PTH might push the kidney hard enough to keep the active form looking normal, even when the total body stores, the 25-OH-D, are actually tanking. So checking 25-OH-D gives you the true picture of overall reserves.
Okay, good point. Now here's where it gets really interesting clinically, the stuff that's easily missed. Our sources talk about drug-induced vitamin D catabolism. So not lack of intake, but the body actively breaking down the vitamin D it has.
This is a huge connection, and yeah, often overlooked, especially with certain chronic meds. Think seizure drugs like carbamazepine, phenytoin, also the antibiotic rifampin.
What do they do?
They're what we call hepatic enzyme inducers. They basically rev up the cytochrome P450 enzyme system in the liver.
Okay, and there's a specific enzyme involved.
Yes, the key one here is CYP24A1. These drugs make the liver produce way more of this enzyme. Now, CYP24A1's normal job is to break down vitamin D to keep levels in check. But when it's massively overexpressed because of these drugs,
It goes into overdrive.
exactly, it just starts aggressively metabolizing both the storage form, 25-OH-D, and the active form, 1025-OH-D, into inactive stuff that just gets peed out.
So the patient is basically burning through their vitamin D faster than they can make or absorb it, even with good sun and diet.
Precisely, which is why a really careful medication history is absolutely essential if you suspect vitamin D deficiency. It also explains why patients on these drugs often need much higher doses of vitamin D supplementation.
Makes sense. Okay, beyond drugs, malabsorption is another big category. Things like celiac disease, or if someone's had a large part of their small bowel removed.
Absolutely. Celiac disease causes that villus atrophy, the flattening of the intestinal lining. This messes up absorption of lots of nutrients, but especially the fat-soluble vitamins, A, D, E, and K.
And vitamin D is fat-soluble.
Right, so it gets poorly absorbed. Over time, this chronic malabsorption leads to persistent secondary hyperparathyroidism. The lab pattern you might see in celiac often reflects this. Maybe chronic diarrhea, low phosphate, calcium that's low or low normal, and that high PTH.
And if this goes on long enough in an adult, it leads to actual bone disease. Osteomalacia. We often mix this up with osteoporosis. What's the core difference again, pathologically?
Good distinction to make. Osteoporosis is about quantity less bone, but the bone matrix itself is normally mineralized. Osteomalacia is about quality. It's a defect in the actual mineralization of the osteoid.
Osteoid being the unmineralized bone matrix, the scaffolding.
Exactly. The body lays down the protein scaffolding, but because there isn't enough calcium and phosphate available due to the underlying vitamin absorption problem, that scaffolding doesn't harden properly with mineral.
So it's like trying to build with concrete, but you're short on cement. The rebar frame is there, but it stays weak.
Perfect analogy. The result is soft bones. This leads to diffuse bone pain, which can feel like arthritis, and this really characteristic proximal muscle weakness. Patients find it hard to get up from a chair, climb stairs, because the muscles are pulling on soft, painful bone.
And on X-ray, there's a specific sign.
Yeah, the classic finding is pseudofractures, also called Looser zones. They look like these little ribbon-like cracks, often symmetric, usually perpendicular to the bone surface. They show where the soft bone is basically bending under stress.
Okay, so that's osteomalacia in adults. The childhood equivalent is nutritional rickets.
Right. Rickets is the same pathology, defective mineralization, but happening in growing children, specifically at the growth plates.
And the context is key here, too.
Very much so. Classically seen in infants who are exclusively breastfed without getting vitamin D drops, or kids with very limited sun exposure. Because their bones are actively growing, the lack of mineralization shows up right at those growth plates.
Leading to those visible deformities we learn about.
Exactly. The physical signs are quite memorable. You might feel soft spots on the skull craniotabes. You see widening and sort of cupping at the ends of the long bones, like at the wrists and knees, because unmineralized cartilage builds up.
And the rachitic rosary.
That's the classic one, yeah. Enlargement of the costochondral junctions, where the ribs meet the cartilage. Looks like little beads along the ribs. Finding this early and treating with vitamin D is crucial to prevent permanent mowing of the legs and other deformities.
Okay, we've really covered the low calcium side hypocalcemia. Now we need to flip the coin entirely and talk about hypercalcemia. Too much calcium.
Right. And here's where the diagnostic tree gets even more branched, because high calcium can come from places totally unrelated to the parathyroid glands.
But the first step, the absolute first decision point, is still about PTH.
Always. You must determine, is this PTH dependent or PTH independent hypercalcemia? That's the fundamental fork in the road.
So if PTH is high, or maybe even inappropriately normal, despite the high calcium, that's PTH dependent. The problem is likely the glands themselves.
Correct. That points you towards either primary or tertiary hyperparathyroidism. The glands are driving the calcium up.
But if PTH is suppressed, low.
Then the glands are trying to shut down because the calcium is high. The problem, the source of the calcium, must be somewhere else outside the parathyroid feedback loop.
Okay, let's start with PTH dependent then. Primary hyperparathyroidism, PHPT. This is the gland itself gone rogue, usually an adenoma.
Most commonly, yeah. A single benign tumor, an adenoma, in one gland just starts pumping out PTH autonomously. Doesn't care what the calcium level is. Less often it's hyperplasia, like all 4 glands are overactive.
And that excess PTH drives up calcium.
Drives up calcium by hitting those same targets, increases kidney reabsorption, increases bone resorption. The lab pattern is typically elevated calcium, elevated or inappropriately high normal PTH, and usually low phosphate, because that excess PTH is still making the kidneys waste phosphate.
Now, often this is found, incidentally, right, on routine blood work, but when it is symptomatic, we have that classic mnemonic: stones, bones, abdominal moans, psychic groans. Can we quickly unpack the pathology behind those?
Sure. Stones, mostly kidney stones, nephrolithiasis, because the kidneys are filtering so much excess calcium. Can also be nephrocalcinosis, calcium deposits in the kidney tissue itself.
Bones.
Osteoporosis. Interestingly, the chronic PTH excess seems to hit the cortical bone, the dense outer layer, harder than the spongy trabecular bone inside. So increased fracture risk is a big concern.
The abdominal moans.
Kind of non-specific GI stuff, constipation, maybe indigestion, sometimes pancreatitis risk is slightly higher.
And psychic groans.
Again, non-specific
Yeah.
but common.
Yes.
Fatigue, maybe depression, concentration problems, sort of cognitive fog, can be quite subtle.
The definitive treatment is surgery, right? Parathyroidectomy. But the criteria for when to operate, especially if someone's asymptomatic, are quite specific. Why is being under 50 automatically a reason for surgery?
Yeah, the guidelines are pretty clear. Age under 50 triggers surgery because the younger you are, the more years you have ahead of you to suffer the cumulative negative effects of chronic hypercalcemia, the bone loss, the kidney stones, maybe even those cognitive effects. It's about preventing long-term damage.
What are the other main triggers?
Other big ones are significantly high calcium, usually defined as 1 milli-GDL or more above the upper limit of normal, any history of kidney stones or evidence of kidney damage like GFR below 60, osteoporosis confirmed on bone density scan, and also a very high calcium level in a 24-hour urine collection, usually over 400 milligrams a day, because that signals a really high risk for future stone formation.
Okay, that makes sense. Now, what about tertiary hyperparathyroidism? You mentioned this evolves out of long-standing secondary HPT, usually in people with end-stage renal disease on dialysis. We really need to get into how that transition happens.
Right. This is a fascinating, almost predictable consequence of chronic disease. Think about the ESRD patient. Their kidneys are failing. So phosphate levels are chronically high and they can't activate vitamin D. Both of those things drive calcium down.
So the parathyroid glands are constantly getting a signal. Calcium is low, make more PTH.
Constantly, for years potentially. This relentless stimulation causes the parathyroid cells to multiply. The glands get bigger, that's hyperplasia.
Okay, they grow in response to demand.
Exactly.
Yeah.
But then, after years of this intense, chronic overdrive, something flips. Some of those hyperplastic cells undergo a change. They become autonomous. They basically stop listening to the body's signals, especially at calcium level.
They develop a mind of their own.
Pretty much. They just keep churning out massive amounts of PTH, regardless of whether calcium is high, low, or normal. It's like the feedback loop is completely broken in those cells.
And the result is severe hypercalcemia, even though the original problem was low calcium.
Exactly. It's a runaway train. The lab picture is really dramatic. Very, very high PTH levels, much higher often than in primary HPT, combined with hypercalcemia, all in a patient who usually still has ESRD and high phosphate because their kidneys still can't clear it. It's a really tough management problem, often requiring surgery to remove most of the parathyroid tissue.
Wow. Okay, shifting gears completely now. PTH-independent hypercalcemia. PTH is low, suppressed. The glands are behaving, but calcium is high anyway. The big one here, especially severe hypercalcemia in cancer patients, is humoral hypercalcemia of malignancy, HHM.
Yes, HHM is responsible for maybe 80% of cancer-related hypercalcemia. And it's often rapid, severe, really makes patients sick quickly. You see it most commonly with squamous cell cancers like lung, but also kidney, ovarian, others.
But it's caused by the tumor itself making something.
Exactly. The tumor cells secrete a protein called parathyroid hormone-related protein, or PTHRP.
PTH-related protein, so it mimics PTH.
It's a remarkable molecular mimic, yeah. The front end, the N-terminal part of the PTHRP molecule, looks very similar structurally to actual PTH.
So it binds to the PTH receptors.
It does. It binds to PTH receptors on bone cells and in the kidney tubules. So it effectively tricks the body into thinking PTH is there. It ramps up bone resorption, releasing calcium, and tells the kidneys to reabsorb more calcium. That's where the hypercalcemia comes from.
But there's a crucial difference, right? Something PTHRP doesn't do that helps us diagnose it.
Absolutely. Key diagnostic point. While PTHRP mimics PTH at the bone and kidney for calcium handling, it does not effectively stimulate that 1-alpha hydroxylase enzyme in the kidney.
The enzyme that makes active vitamin D.
Correct. So unlike in primary hyperparathyroidism, where high PTH leads to high active vitamin D, in HHM, the active vitamin D level, 1025 OHD, is actually low or suppressed.
Okay, so the full lab pattern for HHM is?
Markedly high calcium, often really high, like over 14 milli-GDL, suppressed PTH, high levels of PTHRP if you measure it, and low active vitamin D. Clinically, think rapid onset, severe symptoms like lethargy, confusion, dehydration, often in someone with known cancer or maybe a heavy smoking history suggesting lung cancer.
Got it. Okay, next in the PTH-independent list, Milka-alkali syndrome. Sounds old-fashioned, but you said it's making a comeback.
It really is, surprisingly. Because people are taking so many calcium supplements now, especially calcium carbonate, often for reflux or osteoporosis prevention,
And the classic triad is.
hypercalcemia, metabolic alkalosis, and acute kidney injury.
What's the mechanism? How does taking calcium pills cause all three?
It's a vicious cycle. It starts with just absorbing way too much calcium carbonate. The calcium load causes the hypercalcemia. Now, high calcium itself does a couple of nasty things to the kidneys. It constricts the blood vessels going into the kidney, reducing GFR and causing kidney injury. High calcium also makes the kidney less responsive to ADH, the antidiuretic hormone. So you start losing salt and water, leading to volume depletion, dehydration, and that volume depletion is key. The kidneys try desperately to conserve volume, and in doing so, they ramp up bicarbonate reabsorption in the proximal tubule.
Leading to the metabolic alkalosis.
Exactly. So too much calcium carbonate intake, hypercalcemia, kidney injury plus dehydration, increased bicarb reabsorption, alkalosis. It feeds on itself. Management is critical. Stop the calcium carbonate immediately and give lots of IV saline to rehydrate and get the kidneys working again.
Okay, one more PTH-independent cause. Hypercalcemia of immobilization. Relevant for trauma patients, people on prolonged bed rests.
Definitely. This is a really neat illustration of how important mechanical stress is for bone health. It usually kicks in about, say, 4 weeks after someone becomes significantly immobilized. Think spinal cord injury, multiple fractures, prolonged ICU stay.
What happens to the bone cells?
Well, bone remodeling is always happening, a balance between osteoblasts building bone and osteoclasts breaking it down. Mechanical loading, like weight bearing, is a major signal telling osteoblasts to keep building.
So you take away the loading.
Osteoblast activity plummets. They
Yeah.
basically get lazy without the mechanical stress. But the osteoclasts, the bone-resorbing cells, they just keep going, largely unchecked.
So bone breakdown starts to outweigh bone building.
Significantly, you get increased bone resorption, and all that calcium locked up in the bone gets released into the bloodstream, causing hypercalcemia. The parathyroid glands sense the high calcium and shut down PTH production. So PTH is suppressed, but they can't stop the underlying problem, which is the unopposed osteoclast activity.
How do you treat that?
Best treatment is getting the patient mobilized again, if possible. If not, medications like bisphosphonates are used to directly inhibit those overactive osteoclasts and slow down the bone resorption. So if we sort of zoom out again, connect this back to the bigger picture, it's really clear that this whole endocrine axis isn't operating in a vacuum, right? It's incredibly sensitive to major systemic stress, critical illness, even things seemingly unrelated to calcium.
Yeah, like that example you mentioned, the critical care paradox.
Yeah.
Sepsis-induced hypoglycemia. That seems counterintuitive. Symptomatic stress usually means high cortisol, high adrenaline. Shouldn't that cause high blood sugar?
You'd think so, and often it does initially. But in really severe, overwhelming sepsis or critical illness, a couple of things can happen. First, the body's tissues, especially those activated immune cells, the struggling organs, they become incredibly hungry for glucose. Glucose uptake and utilization goes way up.
Okay, demand increases.
Huge increase in demand.
Yeah.
But at the same time, the septic state, the inflammation, can actually suppress the body's ability to make new glucose. Hepatic gluconeogenesis, the liver making glucose, can falter. Same with the kidneys.
So supply gets shut down just as demand is peaked.
Exactly, the supply chain collapses. And adding insult to injury, if the patient also develops kidney dysfunction, which is common in sepsis, they can't clear insulin effectively. So even their own endogenous insulin, or any they might be given, hangs around longer, further pushing glucose down. It's a dangerous hypoglycemia that can be easily missed if you're only expecting high sugars.
Wow. Okay, another area with dual endocrine impacts is anorexia nervosa, AN. First, the chronic state itself hammers bone health, even in young people.
Absolutely. Chronic starvation, extremely low body fat. This leads to major hormonal shifts. In females, very low estrogen levels. Plus, the chronic stress state leads to high cortisol levels. Both low estrogen and high cortisol are terrible for bone. They severely impair the osteoblast, the bone-building cells.
So even teenagers can get significant bone loss.
Easily. Osteopenia, even full-blown osteoporosis, is a major complication of AIN. And the primary treatment for the bone health aspect is really nutritional rehabilitation and weight restoration, enough to get estrogen production back online and normalize cortisol.
But then there's the acute danger when you start feeding someone with severe AN too quickly refeeding syndrome. This is an electrolyte emergency.
It's incredibly dangerous, potentially lethal. Here's what happens. When someone has been starving, their metabolism shifts to using fats and ketones for energy. Their intracellular stores of key electrolytes, phosphate, potassium, magnesium, are depleted, even if blood levels look okay. Then you suddenly introduce carbohydrates, maybe IV dextrose or aggressive feeding. The body flips back to using glucose. This requires a massive insulin surge.
And insulin drives things into cells.
Drives phosphate, potassium, and magnesium aggressively from the bloodstream into the cells to fuel the sudden switch back to glucose metabolism and rebuilding tissues. The serum levels of these electrolytes plummet, often within hours or days of starting refeeding.
And that crash causes the problem.
Yes, severe hypophosphatemia is kind of the hallmark. Phosphate is critical for ATP, for energy. Low phosphate causes cellular energy failure, muscle weakness, including the diaphragm, leading to respiratory failure, heart failure, arrhythmias, just widespread organ dysfunction. Low potassium and magnesium make the cardiac risks even worse.
So the key is slow and steady refeeding.
Absolutely. Identify high-risk patients, those most severely malnourished, start nutrition support very slowly, like start low, go slow, and aggressively monitor and replete phosphate, potassium, and magnesium before and during the initial phase of refeeding. Prevention is everything.
Okay, one more connection. Common drugs causing fluid balance issues, specifically SIADH syndrome of inappropriate antidiuretic hormone secretion leading to low sodium.
Yes, several drugs can do this. A really clear example is desmopressin. It's basically synthetic ADH.
And ADH tells the kidneys to hold on to water.
Exactly. So if you give desmopressin, or if a drug causes the body to release too much of its own ADH, the kidneys retain excess free water. This dilutes the sodium in the blood,
Resulting in a specific type of hyponatremia.
euvolemic hypotonic hyponatremia. Euvolemic because they aren't necessarily swollen or dehydrated, just diluted. Hypotonic because the excess water lowers the plasma osmolality. And hyponatremia is the low sodium. This is dangerous because if sodium drops too quickly, water moves into brain cells, causing cerebral edema, leading to confusion, seizures, even coma.
So if someone on desmopressin gets confused, checking sodium is the first step.
Absolutely non-negotiable first step. Check the electrolytes, particularly sodium.
Okay, so putting it all together. Sometimes the problem isn't just a simple deficiency or excess. Sometimes it's baked into the genes. Let's touch on a couple of key genetic syndromes, starting with multiple endocrine neoplasia type 2B, MEN2B.
Right. MEN2B is a really striking autosomal dominant syndrome. It's caused by a specific mutation in the RET proto-oncogene. It's a gain-of-function mutation, meaning the RET pathway, which signals cells to grow, is just stuck in the on position.
And this drives tumor growth in specific endocrine tissues, leading to that classic triad.
Exactly. The triad is 1, medullary thyroid cancer, MTC, arises from the C cells in the thyroid and is often very aggressive, can spread early. 2, pheochromocytoma tumors in the adrenal medulla pumping out adrenaline. 3, and this is visually distinctive, mucosal neuromas, these little painless bumps, usually on the tongue, lips, eyelids. Patients might also have a tall, thin, marfanoid body type.
Given how aggressive that thyroid cancer is, the management has to be proactive.
Extremely proactive. Because MTC can be fatal and metastasize even in infancy in MEN2B, the standard of care is prophylactic thyroidectomy.
Removing the thyroid before cancer develops.
Yes, ideally in infancy, as soon as the genetic diagnosis is confirmed through testing for the RET mutation. It's one of the few situations where we remove an organ to prevent an almost certain, highly aggressive cancer.
Wow. Okay, another important genetic condition impacting this whole area, especially growth, Turner syndrome. PS.
Turner syndrome, classic 45X karyotype in females. Lots of potential features, the webbed neck, heart defects, the conatal dysgenesis leading to ovarian failure later. But the most consistent issue is short stature.
And that's linked to a specific gene.
Primarily due to having only one copy of the SHOX gene instead of the usual 2. SHOX is on the X chromosome, and it's crucial for normal long bone growth. Haploinsufficiency, having only one working copy, leads to the short stature.
And managing that short stature involves careful timing of hormone therapy, growth hormone, and estrogen.
Yes, the timing is absolutely critical to maximize final adult height. Recombinant growth hormone, GH therapy, is usually started early in childhood to boost growth velocity. That's step 1.
Step 2 is inducing puberty with estrogen.
Right. Because of the gonadal dysgenesis, they won't typically enter puberty on their own. Estradiol therapy is needed for developing secondary sexual characteristics, and it's also really important for achieving peak bone mass.
But you can't start the estrogen too early. Why the delay?
Because estrogen is the signal that tells the growth plates in the bones to fuse and close. If you give estrogen too early, say before age 11 or 12, while the child is still benefiting from the GH-driven growth spurt, you'll shut down that growth prematurely.
Ah, so you'd limit the final height potential.
Severely. So the strategy is maximize linear growth with GH first, usually for several years, and then carefully initiate low-dose estrogen around the typical age of puberty onset, like 11-12, to induce puberty while allowing growth to continue for a bit longer before the plates fully close. It's a delicate balancing act.
This has been, wow, a really comprehensive run-through from, the subtle nerve signs of low calcium to the specific bone changes in rickets, right up to planning prophylactic surgery based on a gene mutation. It really hammers home how those three numbers, calcium phosphate, PTH, tell such a detailed story.
We've definitely covered a lot of ground and hopefully highlighted how interconnected it all is. Maybe we can boil it down to, say, 3 key diagnostic takeaways for you, the listener, drawing directly from what we've discussed.
Yeah, let's crystallize it.
Okay. 1. If you're faced with hypercalcemia, the very first most critical test is PTH. That single result splits your differential diagnosis wide open. Is it high and appropriate, pointing to primary or tertiary HPT? Or is it suppressed, pointing to malignancy, PTHRP, drugs like calcium carbonate, immobilization, etc.?
Got it. First test for high calcium, PTH.
2. For hypercalcemia, assuming you've checked albumin and magnesium first, the next most useful test is often serum 25-hydroxyvitamin D. If that's low, you're likely dealing with secondary hyperparathyroidism from a vitamin D issue, intake, absorption, or maybe drug-induced breakdown. If the PTH itself is low, then you're back to thinking primary hypoparathyroidism.
Okay, low calcium. Check 25-OHD after albumin magnesium.
And 3. Never, ever underestimate the history, especially medications and supplements. Are they on those enzyme-inducing anticonvulsants? Are they popping calcium carbonate like candy? Have they been laid up in bed for weeks? Finding those reversible causes through a good history can save a massive, expensive workup chasing rarer things.
Excellent takeaways. History, PTH for high calcium, 25-OHD for low calcium.
Exactly.
So before we wrap up, do you have that final provocative thought for us, something to mull over based on all this?
I do, actually. It builds on that idea of tertiary HPT. We talked about how chronic kidney failure forces the parathyroid glands to become hyperplastic and autonomous.
Right, the runaway glands and ESRD.
Now, imagine that patient gets a successful kidney transplant. Their kidney function normalizes. They can clear phosphate again. They can activate vitamin D again. The original stimulus for the parathyroid overactivity is gone.
But the glands themselves.
The glands themselves might still be autonomous. They learned that bad behavior, that uncontrolled PTH secretion during the years of kidney failure. So now, post-transplant, they might continue to oversecrete PTH, causing hypercalcemia in someone with normal kidney function. It essentially looks just like primary hyperparathyroidism now.
Wow, so the scar of the previous disease remains.
Precisely. Which raises a really interesting clinical question. Should we be thinking about this before transplant? Should every patient with long-standing secondary hyperparathyroidism from kidney disease be screened, maybe even treated, for these potentially autonomous glands before they get their new kidney? Could that improve their long-term bone health or cardiovascular outcomes post-transplant? It really makes you think about the lasting impact of chronic metabolic stress, even after the primary problem is fixed.
That is definitely something to mull over. The long shadow of chronic disease. A perfect place to wrap up this deep dive. Thanks so much for tuning in.
Yeah, thanks everyone.
We'll catch you on the next deep dive.